Good morning,
Good
Frank.
morning, Tony.
So nice to see you. Thanks so very much for doing this interview for the Icons Surgery program of the American College of Surgeons. You are the most recognizable vascular surgeons, I dare say, in the world. Tell us a bit about your professional career, a summary, so people will get to know you before we dive into the interview.
Well, yeah, I trained at the Peter Van Brigham Hospital under Francis Moore and Joe Murray, and obviously was around during that training at the early days of kidney transplantation, liver transplantation, and heart transplantation. And when I finished my training, I got involved in lung transplantation because that was the organ that was deemed impossible to transplant for a variety of reasons. Lung transplantation was not feasible, and we were fortunate to make an observation which was really quite critical, and that was that the vascular resistance of transplanted lungs or denervated lungs was thought to be very high, so that it wouldn't be possible to transplant a lung therapeutically in a patient that had pulmonary hypertension, which most of the candidates to receive a transplant would have. So the transplant would have to, the single lung transplant would have to provide total pulmonary function. And we made an observation that as we ligated the opposite pulmonary artery and forced all the cardiac output through the transplant, the ipsilateral pulmonary artery dilated, and what was a normal-sized anastomosis became a area of stenosis, which was quite significant. And when we eliminated that stenosis with a distensible anastomosis, the vascular resistance of transplanted lungs turned out to be normal. That was a really key finding that we fortuitously came to observe. And so lung transplantation then became feasible, and we documented it both in animals and then in one of the first successful human transplants. So I sort of focused on vascular surgery.
You had a lot of firsts, and I'm using the plural of firsts. Um, and I think one of what I believe is the most important, in addition to others that I will touch upon, was performing the first EVAR, the endovascular aneurysm repair in the United States. So could you tell us a little bit of the history of that, especially how did you collaborate with Dr. Juan Parodi?
Yeah, well, that's it's a great story, really. We knew about Parodi's work in Argentina. We had a patient, actually Mike Marin, who was a recent fellowship graduate, was covering me for me on a weekend, and I got a consult about this aneurysm patient with a big, painful aneurysm, but he was too sick to be operated on. With an open operation because of his bad heart and lung disease. And Mike and I were talking about it, and we came up with the idea, why don't we go down to Argentina and learn how to do this EVAR procedure than just an endovascular graft to treat an aneurysm. And I called Parodi up. He knew us or knew me because of our meeting and was very anxious to speak at it. So we developed a relationship. And Brody said that he's not doing any more patients right now, but maybe he would be willing to come up to New York and help us do this first patient. So we sent him the x-rays, and so we brought Brody to Montefiore Hospital where we were. He came and had agreed to do the patient with us. We did the case, and again, we were very fortunate. It worked remarkably well. The next day, the patient was sitting up in a chair eating breakfast, and his pain was relieved, and his aneurysm was excluded. And we presented this work on about 100 cases. I was lucky enough to be the president of the Eastern Vascular and then the SBS, and I made this early endografting experience the subject of my presidential addresses, telling other vascular surgeons, you got to do this stuff because it really works.
Frank, actually, I remember that was like a call to arms for vascular surgeons. And actually, you started that presidential address with the famous Charles Darwin quote. It is not the strongest of the species that survives, nor the most intelligent, but the one most adaptable to change. And you did increase the awareness about amputation. Could you expand a little bit on that?
Absolutely. I made the mistake of stopping vascular surgeons from doing their own arteriograms in our institution. I gave them all to our radiologist, our interventional radiologist, and he got these beautiful arteriograms. Nobody else was getting arteriograms like that. They all stopped, as you say, just below the knee or the mid leg, and they wouldn't see any target artery that could be used for a bypass. But if we saw the arteries in the lower leg and foot, frequently we found patent arteries that we could use for bypasses. And even though they were tiny arteries, but Tony, to go back, the SBS did not treat my presidential address particularly well when I gave it. Everybody thought we were madmen. And we made a couple of other, our one premise was vascular surgeons become endocompetent or become extinct. That was a home run. And I said that 40 to 70% of the procedures we'd be doing open in 10 years would be done endovascularly, either at whole or in part. And they thought I was crazy. Then, as time went on, more and more people were able to reduplicate the effort and see that um, actually I was wrong with my 40 to 70% prediction. They were saying it was much too high. Turned out it was too low. I mean, now, 70 to 80 to 90% of the lesions we treat can be treated endovascularly, perhaps sometimes too much. But the resistance to change is one of the noxious characteristics of human nature.
You've published over 1,000 peer-reviewed publications, and this is not even counting everything else that you publish, and not even counting the endless list of presentations all over the world. You always sit in the front row, and you're focused on the presentations. So I got two questions here. The first question is, how did you get to actually publish over 1,000 peer review article? What kind of tips you may give those of us, or especially the younger generation going up, to be more productive
Well, first of
academically?
all, there's a lot of hard work and there is some talent to writing and rewriting. But actually, the reason I was able to do that is that I had a group and a group of colleagues in vascular surgery when we were at Montefiore. Our little group together uh, was phenomenal. It was a team. It was coherent. Instead of a bunch of rather type A personalities, aggressive guys competing with each other, we basically hung together and worked to be productive and having a group that gets along well and works well together is obviously the way to produce a lot of good research. And I tried to motivate them. I tried to promote each one of them, and that really kept them pretty happy. And they worked together. We jokingly used to say we share everything: money, first authorship, good cases, um, night call, whatever.
Yeah. Well, I mean, corollary to that, a good number of those people that worked with you used to be fellows of yours, and you trained so many fellows, and your fellows are so very grateful to you, and actually and remained loyal to you. And just a few years ago, 4 or 5 years ago, led by Enrico Asher, started this Frank Veith International Society. I go to that meeting every year. in May in New York City, and it's been an excellent meeting. And tell us, if you don't mind, how you felt when a group of your mentees came together and actually put that society in your name.
It felt great. But I love these guys too. Most of them. I guess when they were training with me, I thought I was very benign. They thought I was, a tyrant, but I really wasn't. I never hurt anybody. I don't think I ever fired anybody, either on the professional or non-professional level. Wrote a book which describes some of the stuff we've talked about today: lung transplantation, limb salvage, endovascular, and the theme of the book is not about what we were able to do, the group was able to do together, because it really was a collaborative venture and achievement.
Well, Frank, I'm getting to a point where I wanted to really talk what I feel is the highlight, and what I feel it is actually you've got many legacies, but your legacy, and that's the Veith Symposium. And for non-vascular surgeons watching this video, the Veith Symposium is now an institution. And Veith, actually, even the name of the symposium, Veith, is an acronym for vascular, endovascular issues, techniques, and horizons, but known as the Veith Symposium. What is the secret? What's your secret that this symposium gets better and better and better every year after 51 years of existence? How did you manage to grow that symposium on an annual basis? And also, is it over 1,000, maybe over 2,000 presentations? And how do you manage to find those extremely important and new topics on an annual basis in this number?
Listen, again, I was very lucky. The meeting was started, I think we're in our 52nd year this year, by Henry Hamavici. He ran it for a couple of years. It was tiny. We had maybe 9 faculty and maybe 50 people attending. And after 2 or 3 years, he retired and he turned it over to me. And it was a nothing meeting. I was lucky because, first of all, it was in New York, which is very easy to get to. And secondly, I tried to construct the topics uh, to be what I wanted to hear, that was new and exciting and different, that I could apply to my practice or to our practice. And so there was a lot of luck involved. And then we fortuitously did a couple of other things. Well, first of all, when you said my sitting up in the front of the room listening to every presentation, I basically was recruiting talent
Yep.
to bring to our meeting. If I heard a young person giving something interesting, I go up to him, I get his card, and I'd invite him next year to come to the meeting. So that was one way of recognizing young talent early on and bringing them to a meeting where they could grow and where we could benefit by hearing what they had to say. It wasn't the same old stuff over and over again. So I was very lucky in being able to do that. And I was lucky also that we were the first to embrace as partners industry. And it was partly because of our endovascular interests, and my interest in going to radiology and cardiology meetings to see what they were doing. These guys were really good at what they did, and we could learn from them so we could do what we do better. The idea, which is still going on, of separating doctors from industry is absurd. It's catastrophic. There may be some evil that results from that relationship, but the benefits of it far outweigh the bad effects. The other um, way I was lucky and turned out to be a good thing. The typical talk at a meeting is 10 or 15 minutes. It always was that way, with some expert saying over and over what he'd said many times before. And I realized that if I could invite more people the meeting would be better because I could get opposing views and controversies and stuff like that. And so I kept shortening the length of our talks down to 5 minutes, maybe six, sometimes even 4.5 minutes. So the short talk was a real boon. And now, of course, everybody copies that. But that enabled us to bring uh, 750 faculty and probably have 1,100 talks at the meeting. We cover everything. And hopefully the meeting will go on for many years after me.
Yeah, well, you mentioned that you encourage or you invite young people with great ideas. I was one of those young people, and I remember the first time I received an invitation from you. Uh, I was, first I was extremely surprised, and then I felt this was really amazing, and I felt so honored, but actually nervous. But I also felt that I arrived in vascular surgery because I got invited to the Veith meeting. And from there on, I've been coming to your meeting every single year. The credit squarely go to you, Frank. And for that, I really would thank you on behalf of all of us.
The fact is that the people who come make the meeting. I mean, I don't even give a talk anymore. And I'm moderating less and less because there's so many other good people in our field. And the irony is that, again, going back to my Darwin talk, I was right on the endovascular, but I was wrong on a couple other things. The collegiality between different specialties does work at our meeting, and it does work somewhere. But I had hoped that we could all become colleagues in a vascular institute, a separate department of vascular disease. That hasn't really worked out too well anywhere. Again, because of the foibles and failure of human nature. People don't like to give up the benefits that can accrue to themselves.
Very good. Frank, we talked about the past and the present, very quickly about the future. What are your concerns about our specialty, the specialty of surgery in general, and obviously vascular surgery in particular? Would you care to predict or speculate with the current environment of healthcare and all the challenges that we are facing as physicians and hospitals and institutions? Um, what do you think the future is going to look like?
I think the future is bright, although economically we may suffer. I think that's true in all surgery, or the specialty of surgery, all surgery, because we have a great job. We actually get people better. And I have a saying that uh, good medical care, good doctors are priceless because they take a condition or able to take a condition which is going to wreck somebody's life or cost them the life, and they save them. It's a great profession, so satisfying, but it also has its frustrations and administrative hassles that sort of get in the way. But I think I would do it over again because it is so rewarding in so many ways. We need to get out a large PR campaign to the public, telling the public what it is that vascular surgeons do. That way we'll recruit more good people into our specialty. But to do that, we need to be a defined specialty recognized by our own board and RRC. And that was a third advocacy that I made in my Darwin talk in 1996.
Okay, very good. So, Frank, before I move and ask you about your final comments, I want to say a couple of things. The one thing that didn't come up is Frank Veith as the person. There's one thing that I believe also was a factor in your success, and that's your lovely wife, Carol, who's always at your side at the Veith meeting and in other meetings. And as you know, we all know and love Carol. She's always got a smile and a laugh on her face, and you're always happy and feel more comfortable when she is around you. Also, Frank Veith has, I believe, 12 grandchildren that you care very much about. I would like now to ask you whether you have any final comments.
I'd like to say something about Carol, because I mean, she's been an irreplaceable partner in everything I've done. And without her, I think I wouldn't be anything. I mean, I'm obviously a bit of a workaholic, which has cramped some of the style of some of the things we wanted to do, but without her, I really wouldn't have been able to do anything. And so I think that she's really been the rock of my existence, and still is. I'll tell you a funny story. We went to getting our COVID shots, and we were sitting in the pharmacy waiting to be called. And so she was sitting across from me about 15 feet away, and there was a woman sitting next to me, and she says, "How long have you been married? You're married. You two are married. How long have you been married?" So I said, "Not long enough." And she asked Carol, and she says, "Too long."
Okay, well, Frank, look, thank you so much for spending this time with us. I just want everyone to know he's a fun guy. I mean, in every meeting, you will see Frank with an entourage, and usually you're hearing them from a distance because they're all laughing when they are with Frank. So thank you so much, Frank, and thank you for your friendship over these years. And I
Tony,
have
thank
a good
you, and
day.
thanks for
Thank you.
doing this. I
Bye-bye.
appreciate it greatly. It's been a pleasure.
I'm proud, as the president of this society, to bestow the SVS Lifetime Achievement Award upon Dr. Frank Veith. Frank?
Thank you so much, Tony. Thank you.